Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Taibah Alabdrabalnabi. I am an emergency and EMS physician from Qatif Central Hospital. In this lecture, we're going to talk about OBgyn emergency ultrasound. OBgyn emergency ultrasound is in fact a very important skill for an emergency department physician to have, both to rapidly diagnose patients with intrauterine pregnancy and discharge them home, and more importantly, to expedite patient care who are having real emergencies like ectopic pregnancy. Now, in this lecture, you are going to have a general introduction to OBgyn ultrasound, both transabdominal and transvaginal ultrasound, and then you are going to learn how to define an intrauterine pregnancy, how to measure the fetal heart rate, the age of the baby, and then we're going to go through real cases of both normal and abnormal scans. Now, one of the main indications of doing an OBgyn ultrasound in the emergency department is to rule in an intrauterine pregnancy. And in most cases, if you were able to rule in an intrauterine pregnancy, you'll be able to rule out an ectopic. You will also need to evaluate a patient who is coming with pain, bleeding, or decreased fetal movement during pregnancy. It can also help you evaluate other relevant pathology like retained product of conception, fibroid, ovarian cyst, free fluid in the peritoneum, or subchorionic hemorrhage. Inshallah, in this lecture we'll talk about most of these. Now, there has been multiple researches that support the use of ultrasound in the emergency department. This is one of them. This showed that patients who received ultrasound in the emergency department, we call it point-of-care ultrasound or bedside ultrasound, experienced a 120 minutes shorter ED length of stay as compared to patients who were randomized to radiology ultrasound. So basically, they randomized patients to either point-of-care ultrasound in the emergency department or radiology ultrasound. And what they found is that patients who were randomized to the point-of-care ultrasound had a 2 hours shorter ED length of stay. And this study, they found that the bedside ultrasound done by the emergency physician was consistent with the radiology department ultrasound in 96% of cases. So here the ED ultrasound determination was consistent with the radiology department finding, final outcome or both in 96% of cases. So the ED ultrasound accurately identified 87 pregnancies with intrauterine embryonic structure, including 5 patients with fetal demise. And also they were able to rule out ectopic pregnancies in all of these 87 patients with a negative predictive value of 100%. Now, when we talk about the technique of how to do the ultrasound, we can use 2 probes, either the curvilinear probe or the abdominal probe, or the transvaginal ultrasound. Now, the difference in between the transabdominal ultrasound, transvaginal ultrasound is a low frequency probe, so it has more penetration but less resolution. The transvaginal ultrasound is a high frequency probe, so it's exactly the opposite. So it has high resolution but less penetration. Now, what this means is that basically the transvaginal ultrasound will give you a clearer picture. When you are using the transabdominal ultrasound, of course, having a patient with a full urinary bladder will help you. It will serve as an acoustic window. The transvaginal ultrasound is, of course, less comfortable for the patient, and the orientation is confusing, so you have to make sure that you know where the probe indicator before you start doing the transvaginal ultrasound. So this is an example of doing the transabdominal and transvaginal ultrasound in the same patient. So you can see here the intrauterine pregnancy, the uterus with the intrauterine pregnancy, and the transvaginal ultrasound of the same patient is showing you a much clearer picture. Okay, so ideally we start with the transverse view using the abdominal probe. The probe indicator should be directed toward the patient's right side. And we start just above the pubic symphysis, and then we fan through. We start with the fundus, and then the middle part of the uterus, and then the lower part of the uterus. And then we just rotate the probe so that we have a longitudinal view of the uterus. So this is an example of transverse view. So we start at the fundus of the uterus. It is what we call transverse high, and then we go to the middle, and then you will find that there is a gestational sac with a fetal pole, and then you go down to the transverse low. This is a longitudinal or sagittal view, so you can see here the urinary bladder, and behind it a longitudinal view of the uterus. So this is a dynamic picture, so it is a longitudinal view of the uterus. Now, after finishing doing the ultrasound for the uterus, you go on the adnexa, both sides of the pelvis, to find the ovaries. So ovaries are actually an oval-shaped structure with multiple follicles. It is what we call chocolate chip cookie. So it's like a chocolate chips in a cookie. This is also a dynamic picture. So you can see here the oval-shaped structure, approximately 3 by 5. Okay, now we'll get to the more interesting part, which is going through cases. So case number 1 is a 25-year-old female who came and said, "I think I might be pregnant." And what we want to know here is what to look for to confirm that the patient is having intrauterine pregnancy. So what you see here is what we call a double decidual sac sign. Now the question is this enough to diagnose patients with intrauterine pregnancy? Now, I don't want to go into much details about this, but just for you to know, when the fertilized ovum go and implant inside the endometrium itself will be named differently, just according to how is it related to the fertilized ovum. So the part of the endometrium that is covering the fertilized ovum will be called decidua capsularis. The one that is underneath the fertilized ovum or the gestational sac will be called decidua basalis, and the rest of it will be called decidua parietalis. Now, is this, when you see this sign, which is the double decidual signs, which we talked about, decidua basalis, parietalis, capsularis, this is not enough to diagnose patients with intrauterine pregnancy, and this is very, very important. What you need to see is either one of two things. The first thing is a yolk sac, so not only a gestational sac, but also a yolk sac. When you see this, then you can say that this patient is definitely having an intrauterine pregnancy. This is a dynamic picture, so you can see here a gestational sac and then a yolk sac right there. Okay. And the other thing that you should see, it's either or. It's a yolk sac or a fetal pole to diagnose patients with intrauterine pregnancy. And of course, if you see a fetal pole, you should be able to see a yolk sac. But seeing a yolk sac only can be sufficient to diagnose patients, or is sufficient to diagnose patients with intrauterine pregnancy. Now, I don't want you don't need to memorize all these numbers. The only thing I want you to know is that before 5 to 6 weeks of pregnancy, you will not be able to see anything by ultrasound. Case number 2 is a 40-year-old female, gestational age is 28, is complaining of decreased fetal movement. So what you want to see here is the fetal heart rate. And of course, any movement in the ultrasound could be detected by the M mode. So what you do is that you go and find the heart, and then you press on the M mode. And then you press again on the M mode, and it depends on your ultrasound calibration. In some ultrasounds you can measure, you can do the measurements in between one cycle only, and in other ultrasound machines you have to do it in between 2 cycles. Here it is 2 cycles. Okay. Now, how to estimate the gestational age. Before 12 weeks, you can use the crown-rump length. Crown-rump length is basically the measurement of the fetus from the top of the head, which we call the crown, to the bottom of the buttocks, which we call the rump. The gestational age will be 6.5 times the distance of crown-rump length, but the machine will calculate it for you. After 12 weeks, you can use the biparietal diameter. Now, early on, you're not going to be able to see much, so you can't differentiate, is this the head, is this the chest, is this the buttocks, but what you do is that you measure the longest distance in this oval structure, and you're going to have the gestational age that way. But later on, you'll be able to see the head, the chest, abdomen, and the bottom of the fetus, and that way you'll be able to find the crown-rump length and the gestational age. After 12 weeks, as we said, you can use the biparietal diameter. Remember that biparietal diameter is measuring the BPD from the outer skull on one side to the inner skull on the other side. You measure this at the level of the thalami, or what we call the walnut view. So you find this first, and then you measure the biparietal diameter. Otherwise, you're going to have an inaccurate measurement. Case number 3 is a 45-year-old female with amenorrhea and left-sided pelvic pain. The beta HCG is 65,000. Now, before we go further in this case, you need to know that the discriminatory zone is basically the level of beta HCG above which you should be able to see something with the ultrasound. So in this patient, it was 65,000, which is above 2,500. So you should be able to see something with the abdominal ultrasound. So here you can find the uterus, which is an empty uterus. Here you can see the endometrium. And then you go into the left adnexa, and you actually will find the gestational sac. With a yolk sac, actually. Case number 4 is a 25-year-old female coming with acute onset left-sided pelvic pain, and you go and do the ultrasound. This is what you find. So the chocolate chip cookie, which is the ovary, and then you find a large cyst, fluid within it. So this is a hemorrhagic cyst. Case number 5 is a pregnant lady with perivaginal bleeding. You go and do the ultrasound. This is what you find. So you'll find the covering of the embryo separated from the endometrium with fluid underneath it. So this is what we call subchorionic hemorrhage. The covering of the embryo is called chorion, and there is fluid underneath it, so subchorionic hemorrhage. Case number 6 is a pregnant lady coming with pain and bleeding. And this is her ultrasound. So what you see here is the large fibroid, which could be the reason why she is having bleeding. Case number 7 is a 32-year-old female, 2 weeks postpartum, presenting with abdominal pain, vaginal bleeding, and fever. You go and do an ultrasound. This is what you find. So you find that her uterus is actually not empty, and she's having retained product of conception. So in summary, in doing the OBgyn ultrasound, ideally you will need multiple views. So 1 longitudinal or sagittal view and 3 transverse views, uterus high, mid, and low. And better than this, to have dynamic pictures. You should be able to see yolk sac or fetal pole to diagnose patients with intrauterine pregnancies. After finishing looking at the uterus, go on both adnexy and look at the ovaries. The ultrasound also will help you finding the fetal heart rate and estimate the gestational age. Thank you very much. I hope that this was of benefit to you all, and thanks for listening.